to the Conference on Research on Aging in the Pandemic Age, Regional South-South Perspectives. Now, we will begin the second session of country paper presentations, COVID-19 and Aging Studies. Participants are welcome to ask questions in the chat box. Please welcome the first presenter, Dr. Dinar Dana Karisma, the Deputy Director for Social Assistance, Ministry of National Development Planning, Bappenas, Indonesia.
Okay, thank you. Good afternoon, everybody. I'm very happy that today I'm sitting here and virtually joining this event. Today I am representing the Ministry of National Development Planning, or Bappenas, in giving you information or sharing with you some of the initial finding that we get from our phone survey. And well, it was actually not a phone survey, but it was a data census style data collection that was conducted in 2019. But we managed to then conduct a phone survey this year to see the situation after the COVID-19. So as you can see here, that this is a research that that has been done by several people, and this is going to be a chapter in a book as well, the one that we are working on right now. And I am representing all of the speakers, and to give you some of the initial findings from the research. Can you go to the next slide, please? So this is some of the background information. As you may have known, Indonesia is currently entering the aging population, and near to 10% of the population, based on the latest data set in 2019, are older people. Unfortunately, we have quite limited programs in place for older people, and those programs are still conducted separately. So we realized that the data and knowledge on older people have been limited. The Bappenas then initiated to develop Silani, or Older People Information System. And we initiated this together in coordination with some of the line ministries, like the Ministry of Social Affairs, Ministry of Health, as well as the Family Planning Agency. And it was supported by several development partners, including AREA, ADB, UNFP, and Surveymater. So we piloted the information system by collecting data of about 14,000 older people in 7 villages in 2019, around end of the year. And then the COVID-19 happened in Indonesia, and then we decided to follow up with phone surveys. And the phone surveys consist of 2 waves, and the first one was just recently completed on July 2020. The phone survey itself was conducted on a subsample drawn from the 2019 baseline, and it created panel data sets which allow us to compare with the situation of the older people before and during the pandemic. Next slide, please. So this is a little bit more information on the Silani baseline 2019 and the phone survey that we conducted in July 2020. And the second wave of the phone survey will be is currently on progress now on November and December 2020. So the Silani baseline 2019 covers 5 domains to determine long-term care need among the older people, including ADL, IADL, dementia, disability status, as well as depression. And we were using GDS, Geriatric Depression Scale, consisting of 15 factors that you can see here for the to determine the mental health status of the older people. And then the Silani was also covering older people household characteristic, including their socioeconomic status. And the aims is to support service provision and planning and program planning for older people. The phone survey, on the other hand, didn't was not as long as the baseline, and as I mentioned earlier, it only conducted on a subsample of the baseline. And many of the questions were actually not re-asked, but some of the questions we managed to ask again. And of course, because this is phone survey, we couldn't ask too many questions because we didn't want to be too long in the phone call. So only questions on depressions were asked again, but instead of using 15 GDS, geriatric depression scale, we only used 5. And it was actually based on research as well that GDS5 is actually quite consistent with the GDS15. So if you see the green box in the lower side, you see the complete 15 GDS that we use for the baseline, and then the scales that I highlighted with red fonts are the GDS5 that we use for the phone survey follow-up. And then the phone survey also covers more detailed questions on social assistance as well as their health behavior during the pandemic. And the aim was to assess the impact of the COVID-19 pandemic on older people well-being. Next slide. So there are many data information collected through the phone survey, but focusing on the research that I'm going to present today was the focus of the research that I'm going to present today is the mental health of the older people. So these are the research questions. What is the mental health situation of older people during the COVID-19 pandemic, especially in the Silani regions where we conducted the both data collection and the phone survey? What are the dynamics of older people mental health before and during the COVID-19 pandemic? What are the associations between mental health indicators and other older people characteristics, such as their gender, where they live, the regions, health status, socioeconomic status, as well as their communication with family and friends? The analysis method is still quite not very sophisticated for now because we are still waiting for the result of the second wave of the phone survey. So for now, I will only be presenting some of the descriptive statistics, tabulation and cross tabulation. So you will see a lot of graphs rather than regression result, for example. And we try to do some simple panel analysis comparing older people's situation before and during the COVID-19 pandemic. Next slide. So these are some of the descriptive statistics to give you some backgrounds on the survey. So the baseline at the end of the 2019 collected data from about 14,000 older people spread in 7 villages in Jakarta, Day Yogyakarta, and Bali. Yogyakarta and Bali are 2 provinces in Indonesia with the fastest rate of aging. So that's why we focus on that. On the regions. For DKI Jakarta, it was because the number of the population is quite big, so we were also focusing on that. And then some of the phone surveys were not able to reconnect with all of the Silani older people recorded in Silani, and even though we have a randomized the subsample, it was quite difficult because many older people didn't have a phone or were not able to be contacted through phone because the phone were owned by their kids or their family. So some of the comparisons show you the differences that show the situation. For example, in DKI Jakarta, for the baseline, it was only 47% of the older people live in DKI Jakarta, but the phone survey showed that more of the older people that we were able to contact for the phone survey were located in DKI Jakarta. So the rate increased from 47% to 53%. And many older people in Yogyakarta, they didn't have phone or mobile, either landline or mobile phone. So we lost a lot of representation of older people from the Yogyakarta. For the average, it's not too different, but slightly those who responded to our phone survey were slightly younger. Um, Education-wise, more older people with education are responsive to the phone survey than the one without education. So for the baseline, about 12% of the older people, we managed to identify that they didn't have any education. And for the phone survey, only 8% of them actually responded. Um, those who work were less likely to respond to the phone survey, which is making sense because probably they were busy or they didn't have time to talk to the phone. So only 40% instead of 51% compared to the baseline, the older people that were responding to the phone survey. And then those with health issues are those without any health issues are more likely to answer the phone survey as well. And so we managed to identify that about 10% of older people in the Silani regions, based on the baseline, need long-term care. But when the phone survey conducted, only 3% of them, based on our total sample, only 3% from our sample categorized as older people who needed LTC. So apparently they were also less likely to respond through this phone survey. So this is some of the comparison between the baseline and the phone survey. Next slide. So these are some of the situation of the mental health before and during COVID-19. On the left-hand side graph, you can see that we covered some of the. This is part of the GDS. Some of the questions were like whether or not you feel dissatisfied with life, whether or not you feel bored, whether or not you feel helpless, and whether or not you feel worthless. The blue one is representing the situation before the COVID-19 pandemic or end of 2019, at least in Indonesia, because we haven't really heard about the COVID-19 by the end of 2019. And then the orange one is after. So you can see that some of the signs of depression based on the GDS increased dissatisfied with life. More older people felt dissatisfied with life after July 2020, and more older people also say that they are bored. Interestingly, less of them said that they're helpless, and less of them also said that they feel worthless. So this is interesting. So and there may be some connection with the situation that they stay at home, and probably they stay with the family, and more family members spend more time in the home, so they feel happier, less helpless, and less worthless. That's some of the possibility. And we also ask whether they feel anxious or not during the pandemic, and what are the causes of their anxiety. And 44% say that they are anxious about their own health. 50% say they are anxious about their family health. 34% feel anxious about their economic security, and about only 3% anxious about their access to food. And it's probably more on the economic security than food, the anxiety that they felt. Next slide. So this is when we cross-step it with gender, we found out that female older people in general have worse mental health. So only on the question of dissatisfied with life, female older person have slightly less prevalence to say yes compared to the male older persons. But the other GDS questions were more likely to be answered by yes by the female older people. They felt more helpless, they felt more bored, and they felt more worthless compared to the male older people when they were asked about their feeling. And for the anxiety during the pandemic, female older people, they're more likely to be worried about their own health and family health, even though only slightly compared to the um, male older people. But male older people are very slightly more likely to be worried about economic security and access to food. And then next slide. In terms of regional variation, we find a lot of stress in Jakarta, which is understandable knowing the living situation in Jakarta compared to the other regions. However, we find in a very significant increase in terms of depression signs in Bali. So if you see, for example, on the upper left graph, dissatisfied with life, the situation in Jakarta, the percentage of older people saying that they are dissatisfied with life increased from 13% to 16%. The age of Jakarta is always low everywhere, but Bali increased very significantly from 8% to 22%. And it also happened in other other questions, like whether or not they felt bored. Bali increased very significantly, and whether or not they felt helpless. So in other regions, there were some significant decrease, but in Bali, the situation didn't really change. So this is something that is also interesting, but to be honest, I don't know what's the answer why in Bali, because probably in Bali they depend more on the tourism and felt the situation is more stressful when they cannot do the economic activity, the tourism activity. That's a possibility. Next slide. And then depression signs are correlated with socioeconomic status. You can see that this is I'm graphing the incidence or the prevalence of older people saying yes to some of the questions in the GDS with the quintiles. And as you can see that lower quintiles, older people in lower quintiles, economic quintiles, tend to say yes, tend to be more likely to show a depression sign. However, if you see the COVID-19 pandemic seems to affect the wealthier more. So if you see the one in the upper left, for example, dissatisfied with life, all of them experience increase in the number of older people who said that they are dissatisfied with life. But the highest increase happened among the wealthier group of the older people, and that also quite consistent with the other questions as well. So this is interesting that to begin with, that less wealthier older people are more depressed, but the COVID-19 affect them differently. So the increase of the depression sign is actually faster among the wealthier older people. Next. So this one is when we cross tab the depression sign with health status. We define health status with needing LTC. So active means that these older people don't have any health issues, while need LTC meaning that those older people have some health issues that require them some LTC. So depression signs are correlated with health status in a way that those who need LTC in general are more depressed. However, again, the pandemic has more negative effect on active older people or those who do not need LTC. And those who don't need LTC, I don't show the data here, but they also tend to be more worried or family health, while older people without LTC are more worried about economic security and access to food. Next slide. So this is one of the last results. I think there is an indication that communication and interaction correlate with older people mental health during the pandemic. So we try to see the sign of depression based on whether or not they communicate with family. So you can see in the left side, there is some of them are always communicating with the family, some of them only sometimes, and some of them never communicate with their family. And whether or not they still do activities outside the house despite the pandemic, Some of them still do activities outside the house. Some of them sometimes. Some of them never after the pandemic. Some of them actually never do any activities outside even before the pandemic. And we see some indication that those who are always communicating with family or sometimes communicating with their family have a slightly better mental health condition compared to those who never communicate with their family, and also those who are still active, which is not a good case actually during the pandemic, but some of them are still active, and some of them show better mental health situation compared to those who never do any activity outside anymore. Next slide. So I'm not sure if I still have time, but this is my last slide. So our research basically trying to find some indication of the correlation between COVID-19 pandemic and older people's mental health. And since we managed to do some cross-tabulation with some characteristic of older people, we hope that we will be able to identify some of the subgroups of older people with higher risk with mental health problems, or especially during the pandemic COVID-19. And we think that this should be able to be addressed by some of the government policy, for example, social protection scheme that is more adaptive toward the disaster situation or a pandemic like this that will be able to adapt and change according to the needs of older people during the pandemic. We think that integration is the key, so that's why we are now piloting on integrated older people care, and the pilot will be conducted in Bali and Yogyakarta in the location where we did Silani. We try to put together all of the institutions that are conducting older people programs and try to do more holistic programs for the older people care, especially to those who need LTC, but also we will provide some programs to active older people. And Silani Digital Platform is something that we are now developing. It's an online platform for both of the case managers, social workers, health workers, and even the older people themselves. So they will be able to connect, to contact each other, to help each other without having too many physical interactions, especially during pandemic. We do think that this will be pretty helpful. We do realize that there is a digital divide between older within older people. So we are also now working on how to work on this, on reducing this digital gap between them. I think that would be all of my presentation. I'm sorry if I talked too long. Thank you so much. And I'm looking forward to hear your comments or questions.
Okay, thank you, Dr. Dinar. There is one question for you from Associate Professor Dr. Doris. The question is, do you think the studies show better mental health for elderly during COVID-19 pandemic, since the children and grandchildren are more at home? Please comment.
Yeah, that is very interesting. So our results show mixed results. We asked several questions from the geriatric depression scale, and two questions: whether or not they feel dissatisfied and whether or not they feel bored, have shown that older people feel more dissatisfied and more bored during the pandemic, which is showing a higher sign of depression. However, two other questions on whether or not they feel worthless and helpless didn't show the same direction. So actually, they less older people feel worthless and helpless during the pandemic. So I don't know whether this is associated with the pandemic. We do ask questions before and after the pandemic, but as you know, the previous one, the one that we did in 2019, was a physical survey where the communication between the enumerator and the older people are physical and more dynamic. While the first wave phone survey that we conducted in July 2020 was less engaging since it was conducted through phone. So I think we should be careful in interpreting whether or not there are changes in the mental health status of the older people. And hopefully, we will get more information after we are done with the second wave of the phone survey. But the indication now, if we think that there's no significant difference between physical survey and phone survey, the indication that there are some indication that older people feel less worthless and less helpless during the pandemic. And that's probably because they are surrounded by the family more, or they play more role in the family, such as childcare when some of the family members cannot go outside or have to stay at home.
Okay, thank you, Dr. Dina, for your explanation and presentation. Next, please welcome Professor Dr. Grace T. Cruz from University of the Philippines Population Institute, Philippines.
So we all know that the COVID-19 pandemic has placed the Philippines in the throes of the worst public health crisis not seen in the country's history in recent memory. Almost a year from its onset, the Philippine government has yet to contain the pandemic. To date, we have recorded almost 500,000 infections and about 9,000 deaths, majority of which are older people 60 years and over. Measures have been put in place to contain the pandemic to include the community quarantine, which have drastically altered the way we conduct our daily activities. Besides the major impact on health, the pandemic has caused a severe economic downturn. The country's GDP is expected to shrink by 8% this year. Adding to our woes are the weaker remittances from overseas Filipino workers. With jobs lost, poverty increased, and hunger hit an all-time high. Hunger rate was at 9% last year in December, which more than tripled to 31% September this year. So the question is, to what extent have these changes impinged on the well-being of the older Filipinos? Using the baseline data of the 2018 Longitudinal Study on Aging and Health in the Philippines, or LSAP, I will try to explore the challenges imposed by COVID-19 and on the health and economic well-being of the older Filipinos. Next slide, please. So LSAP is this is the basis of my presentation, the LSAP data, and I will also get some information from the COVID-19 tracker of the Department of Health here in the Philippines. So the LSAP is the first nationally representative longitudinal study on aging conducted in the country. It is designed to investigate the health status and well-being of Filipino older people and their correlates and assess the determinants of health status and transition in health status. Next slide, please. LSAP data includes a nationally representative sample of almost 6,000 respondents aged 60 years and over who are living in community dwellings. We oversample those who are at ages 70 and over so that we will have enough respondents in the follow-up survey that was supposed to happen this year, but due to the pandemic, it might be postponed to early next year. It is a multi-actor study that includes information from the older person respondents, their caregivers, and one of their adult children. So the LSAP data was collected sometime October 2018 to early 2019 or prior to the pandemic. The study is being funded by the Economic Research Institute for ASEAN and East Asia, or area. Next slide, please. I would like to start my discussion by looking at the state of COVID-19 infection in the country. So this slide shows us the shifting age structure of COVID-19 infections. Notice that at the start of the pandemic in the country, the infections were mostly concentrated in the older age groups, with the 60-year-old and over sharing at least 16% of the total infection, although in the population, the older persons only share 8% of the total population. But we see that over time, the age structure has changed with the increasing proportionate share of those coming from the younger ages. So as of now, December 2020, the share of the older persons, 60 years and over, to total infections has been reduced slightly to 12%. Next slide, please. So the changing age structure is also evident in this graph, which shows the increasing share of the younger population sector and the declining share of the older people. The vulnerability of the older people to COVID-19 is evident in the significant share of those older ages among the COVID-19 deaths in the country. So we see here that over time, there is a declining share, but it's still high at 71% of all deaths as in March when we started to monitor the COVID-19 deaths in the country, and it's now down to 62% as of December this year. Next slide, please. So the high COVID-19 infections and mortality risk of older Filipinos can be attributed to their current conditions, with about 58% among them reporting having been diagnosed by a doctor to have at least one of the risky comorbidities of COVID-19. These comorbidities include high blood pressure, diabetes, myocardial infarction, chronic respiratory illnesses, cerebrovascular diseases, or cancer. Obesity also puts people, particularly the older people, to many other serious chronic diseases and increases the risk of severe illnesses from COVID-19. So the LSAP findings show that at least 8% of our older persons are obese, and we see that the findings show more of the females than males are overweight or obese. That puts them at a higher risk to possible risk factors to COVID-19. Next slide, please. So related issue is the poor health care access among older people. According to our study, it shows that a considerable proportion of our older persons have unmet need for healthcare services. At least 29% said that in the last 12 months or the year prior to the study, they felt ill and thought about seeing a doctor, but they did not do so. And if you ask the reasons why, most of this unmet need for health services is due to economic reasons. Next slide, please. So this leads us to the major vulnerability among older Filipinos, which is economic vulnerability given the high level of poverty. Generally, we see that older Filipinos are poor. 46% are living below the poverty line at the time that we conducted the study in 2018. This is higher compared to the overall poverty level in the country, which is less than 20% or about one-fifth of the population. Results also show that 14% said that their household experienced hunger in the last 3 months. They also, about half of them, also said that they grew up in what they consider poor families. So we have all the indicators showing that older persons seem to be coming from the economically vulnerable group. Next slide, please. So older Filipinos have fragile and informal sources of economic support. Older women in particular are highly dependent on the financial transfers from their children. This result shows us that 26% consider remittances from children within the country as their most important source of income, and another 10% say it's remittances from children abroad. So here we see also the effect of international migration on the economic well-being of older Filipinos. A lesser proportion depend on earnings from work. But the story is different for the older males who consider work earnings from work as their most important source of income. So, based on these findings provided, we see that when you look at the objective indicators of economic status, it's not surprising that we see a very high level of self-assessed economic sufficiency. There's a high level of unmet need for economic needs of the older persons, with about 57% of the respondents saying that they have some or considerable difficulty in meeting their household expenditures. Next slide, please. So, how has the government responded to the COVID 19 pandemic that has affected the older person's way of life? So, in response to the growing threat of the pandemic, and with the aim of protecting the vulnerable sectors, the Philippine government has instituted certain policies, one of which is what we call the Enhanced Community Quarantine or ECQ, which required a total lockdown for several months. For high density areas in Metro Manila, where there was a very high concentration of COVID 19 infections, there was even a period where there was a very hard lockdown that was implemented for selected areas. Next slide, please. So ECQ or enhanced community quarantine restricts non-essential movements of individuals with special emphasis on persons who are at high risk of being infected. And this includes those who are 60 years old and over, and those who are immunocompromised or with comorbidities such as lung and heart disease and diabetes. So the ECQ also prohibited mass gatherings, including religious ceremonies. There was a closure of establishment and a ban on public transportation. So the age-based stay-at-home restrictions were eventually amended because there were a lot of complaints coming from the older sector of the population who thought that such policies were ageist. So now it has been revised and amended so that now only those who are 65 years and over are restricted from leaving their residences. Next slide, please. So such policies were resisted, no, like as I mentioned, by several sectors, particularly the older persons, because home confinement deprives workers from their main sources of livelihood, food, and other necessities. Those working in agriculture sector, for instance, were unable to sell their products because there was a ban on their transportation. There were restrictions of movement. Repatriation of overseas contract workers, for instance, which another effect of the pandemic, is expected to affect the remittances of children to their aging parents. As I've showed you a while ago, a significant proportion of older persons, particularly the females, are saying that their most important source of income are transfers or remittances from their children who are working abroad. Next slide, please. So ECQ restrictions due to COVID-19 has also led to some home confinements, right? That led to a more sedentary lifestyle. So this means that older persons are unable to do their usual activities outside their homes, and therefore this disruption of normal routine activities presents a threat to their mental health. So next slide, please. So in conclusion, it's clear from our findings of the study that older Filipinos are disproportionately affected by COVID-19. So while they constitute a mere 8% of the total population, they share at least two-thirds of the reported COVID-19 deaths in the country. COVID-19 is expected to further magnify the already vulnerable older persons. We have clearly demonstrated based on the results of our study that even before COVID, older Filipinos were already in a poor economic and health state. And therefore, with the lockdown and their factors that affect their sources of income, we expect that this is going to increase their vulnerability. We also see that the repatriation of many overseas contract workers as a consequence of the pandemic will have a serious economic and other related implications on the income sources of our older persons. Next slide, please. We also saw that at least 58% of Filipinos have at least one of the risky comorbidities for COVID-19 that make them highly vulnerable to COVID-19 infections, particularly with the high levels of unmet need for health services due to economic reasons. So in the context of limited government resources to mount a workable response to the pandemic, ensuring the safety and protection of vulnerable groups like the older Filipinos will require a collaborative effort from government, private, international development organizations, and among others. At this time of the pandemic, the Filipino family will assume a most important role, particularly in the care of the vulnerable groups like the older people. So with that, thank you very much for your attention, and I would like to take this opportunity to thank the organizers for inviting me to present the results of our study. And we'd like to, next slide please, to thank the funding source for our project, the area. Thank you very much.
Thank you, Professor Dr. Grace. There are some questions for you from the same participant. Is the age distribution of COVID-19 positive cases that you showed based on cases in the preceding 2 weeks? That's one question. The other questions is, are there numbers or rates that is adjusted for the number of tests done at different ages?
Thank you for those questions. The problem is that the data coming from the DOH tracker from the Philippines is quite limited. That is why those information that I showed you are just the data collected by our institute based on what has been released by the Department of Health. But there has been issues about the consistency of the information that are released by the Department of Health, and we don't have an idea how many have been tested. All we have are reports of total infections, recoveries, deaths on a daily basis, and that is what we collect so far. And the basic information that we have collected are just age and sex and nothing more than that. So it's really quite a limited analysis that we are able to do based on the available information.
Thank you, Prof, for your explanation and presentation. Moving on to the next presenter, please welcome Professor Dr. Tan Maupin from Faculty of Medicine, University of Malaya, Malaysia.
Hello, thank you for that introduction. So I'm going to share with everyone our findings from the Ageless study, which is actually a longitudinal study of a cohort of aging in Malaysia. And even though we've got wave 1 at the moment, this is actually the combination of 2 existing cohorts, the MALAW study, the Malaysian Elders Longitudinal Research Study, as well as the Towards Unusual Aging study, the TUR study. TUR means old in Malay, which actually started in 2013. So I'm going to present primarily data from MALAW, and I will leave Professor Susana Shaha to actually talk about the data from the TUR study later. She's going to present that data. So just to 19 in Malaysia, we are we're not doing tremendously well, but we're not doing too badly either, in that we have had a total of 86,000 cases, and the number of cases is going up at a speed that we've never seen before. So we've stopped being able to produce micro data. In the first wave, first and second waves, we were very good at micro data, but third wave, we've lost the plot. So but with regards to death, it's only 422 deaths, and the death rate is 0.4%, which is actually extremely low and a testament to the fact that we have actually shielded the vulnerable people very well. The mortality rates are actually about 60% over the age of 60, but that was actually based on data that was published back in May. We've not had any updates with regards to the age breakdowns of people who die, but looking at we report deaths every day. So we stare at the death. I wish I captured the death statistic on a daily basis, but it's a little bit difficult to keep up. But we always see that most of the deaths occur in over 60, especially the over 70s. Okay, so with that background, what we're going to look at COVID-19, the effects of the movement restriction disorders on our older Malaysians, so we are going to actually share some of the findings from the preliminary analysis of the first wave of the LRGS ageless study. Next slide. Okay, so just to put a bit of picture on, I've already mentioned that the ageless longitudinal study of aging is actually the merger between two existing cohort studies that started in 2013. So we actually struggled for a long time to get continued funding for these two cohorts. And it was through the merging of this cohort that last year we finally secured funding to actually look at these two, to harmonize these cohorts and to follow up participants of both cohorts together. And we gave it a new name called the Ageless Study. But then it was rather unfortunate that when we finally got the money landed at the University of Malaya. We've been given the privilege or the task of heading this study, and the money landed just before the movement control order. So we couldn't even distribute the money for 2 months. And we eventually got the money to the other universities. And, after that, we were just a little bit gobsmacked about how we're going to totally change the way we collect data in aging studies in order to make it possible to find out what's going on in our older adults in COVID-19. Failing was not an option because we really needed to know what was going on with our older people during this pandemic. So we actually decide, after much debate, we decided to persevere and to see what we can do using virtual interviews. So what we did was to develop these virtual interviews is basically we started with a focus group discussion involving key stakeholders and also participants. So we call this patient public involvement. And we actually managed to get people aged between 60 to 79 to participate in a virtual focus group interview. It was more challenging than normal, but normally the challenges are finding parking, actually getting them to the right place because there are lots of traffic jams and the roads are not properly signposted, etc. And the hospital is not properly signposted, so they usually get lost coming to us. But now our new challenge was to actually get them to stick to a virtual interview, making sure everybody had their mics off at the right time, and we kept having to remind people to turn their mics back on. Some people had connection issues, but all that got resolved, and we succeeded in actually connecting 12 older individuals in a focus group discussion. It lasted 90 minutes, and it was incredibly informative. And then with our researchers, Malaysians are warm people. We like to meet each other. We like to eat together. We like to hug. We like to talk. And so suddenly we have to totally change the way we do things as well. So instead of having group discussions face to face, we actually did an primarily email-based exercise, and it was a modified Delphi exercise. But this was actually aided by one semi-face-to-face session, followed by two kind of virtual meetings, and this Delphi exercise took about a month, and then we piloted it, pilot it in terms of recruitment, and also how successful we were able to control to actually perform the interviews, how long the interviews took, and this pilot exercise only occurred within 1 week. So things happened in a much shorter phase. We normally take much longer to do all these things, and we usually do it in bigger numbers. Next slide, please. Okay, so this is what we found with the group discussions. We were very pleasantly surprised that we could find 12 older people who all told us that they were on the social media all the time. They had several gadgets that all were connected to the internet, and they used the internet for exactly the same things as we would use the internet for. We were surprised, but then later we laughed at ourselves to find out actually why wouldn't they? So they communicated with each other a lot. They use internet for banking. Malaysia is quite unique in the sense that our banks switched to online, almost exclusive online banking quite a long time ago. And if you tried to go to the bank, they would actually make you do the transaction online in front of them. So they actually taught customers how to do online transactions, and that was way before the pandemic descended. And they used it a lot for leisure, of course, to watch a lot of movies and things like that. And they also used it for learning, lifelong learning. So that was quite fascinating to all of us. And some of them used it to actually do voluntary work. They taught kids how to speak English or read and write in English through working with an NGO. Next slide. Okay, so we initially had compiled the exercise through the semi face-to-face interview. So people met within their institutions, but then we all dialed in between the institutions. So we had groups that dialed into each other. So we decided on these multiple components. You could probably guess that it's not possible to do this during a COVID pandemic because we needed to prioritize, and there were some questionnaires that they would have not made no sense trying to do them in a pandemic, especially like the physical activity one. They'll be asking about outdoor activity when you're not allowed to go outdoors. So eventually we picked the questionnaires that we could actually administer during the pandemic. Next slide. Okay, and this was the interview training. Now, the next job was to actually persuade young people that old people could do virtual interviews. So we actually had this exercise where they actually found out how many people had smartphones and what the internet connectivity was like in Malaysia when the telephone was invented, because most of them thought that older people wouldn't know how to use the telephone. And when the television was invented, those sort of things, to actually persuade younger people that they could actually interview older people through virtual means. And then the other thing that we actually encountered an issue with was that young people was not familiar with actually communicating. Yeah. Verbally. So we had to actually work on some of the communication skills as well. Next slide. Okay, so these were the COVID questionnaires. Okay, so we asked if they had more trouble sleeping during the COVID pandemic, and whether they felt more isolated, and whether they avoided going to see a doctor. Those were just those three concentrated on COVID, and 7.7% said they had lost sleep, had more sleep problems. 14% said they felt more isolated, and over 10% said they had avoided seeing a doctor during the pandemic. Next slide. So because we had the baseline data, but the baseline was 2013, so you have to take this with a pinch of salt. We could also compare quality of life between people pre-pandemic and post-pandemic. So you can probably see there is not a huge lot of difference, but the things in the red boxes are the ones that differed. So basically, fewer people felt out of control. Fewer felt left out during the pandemic, but more felt that they could do things to please themselves. Fewer felt that they had that life was full of opportunities, and fewer felt that they had more energy, had a lot of energy. So it was more or less balanced. In some components, some questions they actually improved, some questions they did worse. Next slide. Next slide, please. Okay, so this one is the anxiety score. So we use DAS21 to measure anxiety. So with regards to anxiety, basically we felt the overall anxiety reduced during the pandemic, and our older people had far fewer anxiety symptoms across the board. Next slide. Okay, so when we compare the quality of life, total quality of life scores, pre and post pandemic, no change. Anxiety scores, pre and post pandemic, significant reduction in anxiety scores. Next slide. But it doesn't tell the whole story, of course. So when we compared the change in anxiety scores with the change in quality of life scores, as you would expect, there was a weak correlation between increased anxiety and reduced quality of life. Next slide. Okay, so, but this doesn't tell the full story. So, because the only reason why quality of life didn't change was because some got worse and some got better. So, and same with anxiety, some got worse, some got better, but fortunately for anxiety, more got better and fewer got worse. But for quality of life, it balanced out. So we've divided it into 5 groups for both anxiety and quality of life scores. Next slide. Okay, so and then we compared that to our COVID questions. So what we found was the people who had reduced quality of life actually were more likely to have not seen a doctor. And then the people who had whose anxiety scores had worsened were actually more likely to have sleep problems, more likely to feel lonely, and to feel more lonely, and more likely to avoid seeing a doctor. Next slide. Okay, so that's the end of my talk, and I'd like to thank the whole Ageless team for this incredible monumental effort in actually achieving something over a very short period of time and totally changed the way we collect data from Malaysian older people. As you can see, this is a picture of our pseudo workshop, face-to-face workshop, and so we had groups dialing into each other, and the team actually comprises of over 50 investigators, and the blue square actually shows all our research assistants and our enumerators. So thank you, everyone. Please do contact us on our email or check out our Facebook page for more information.
Thank you, Prof. Dr. Tan. There is no question for you, so thank you very much for your presentation. Next, please welcome Associate Professor Dr. Evi Nurvidya Arifin from Center for Advanced Research Care, University Brunei Darussalam.
Hello, good afternoon, ladies and gentlemen. First of all, I would like to thank the National Population and Family Development Board and Malaysia Research Institute on Aging, My Aging, for inviting me to participate in this conference. My presentation is about hearing disability among older persons in Indonesia. Lesson learned for the COVID-19 pandemic. As reported in WHO 2018, next slide, hearing loss is the 4th main cause of hearing disability globally. Sorry, can you move to the next slide? Yeah, so hearing loss is the 4th leading cause of disability globally, and hearing loss affect millions of people around the world. Is about 406 million with disabling hearing loss in 2018, and this one an increase from 360 million a decade ago, and that this projected to reach 630 million in the next 10 years. So people with hearing disability is among people who have hearing loss, based on the 2012 data, is about 100 million older adults. So this poses a cause for concern, especially with regard to the current condition during the pandemic. Next slide. So this slide shows from the work of WHO in 2010, the projected number of people with hearing loss in different regions. In 2018, in ASEAN countries, which is in this slide, is belong to East Asian region. So in this part at the right one, in 2018 is about 47 million people suffering from hearing loss, which is will be projected to be 64 million. So that in terms of the size, which actually across region have different size that you can see. And then with regard to the most important thing, the next slide presents the prevalence. Next slide, please. And the prevalence of disabling hearing loss. So from this slide, it shows that in South Asia, it's about 48% of the older persons, 65 and above, experience hearing loss. And then Sub-Saharan African, 44%, and East Asia, that where ASEANs included, is about 34%. But what is more in this slide actually shows that there is a relationship between the prevalence of hearing loss with the economy, which measured by the average gross national income per capita. And this slide shows there is a negative association. As the income per capita increase, the percentage of people with hearing loss is tend to be smaller. The next slides. The next slides, this one I think is also an important thing, because due to the significant number of people with hearing disability or hearing loss, then since 2018, every year on the 3rd of March, that become World Hearing Day. And then next year, in 2021, the theme for World Hearing Day is on hearing care for all. And then I think will be relevant to us as COVID, I think, will still be with us, because next year is just a few more weeks. So next slide shows that. So that's here. Why hearing? We study about hearing disability, that hearing is one of the most important sense in human. But yet I think hearing disability is one of the often neglected topic in research and also policy making. And then especially in this case for older person. So hearing disability is become very much important in relation to also 3 global movement and 3 global situation, which we have sustainable development goal, which is no one left behind. And I think this is the important thing. In many cases, people with hearing disability are excluded. So with sustainable development goal, we have to bring people with disability, especially older person with hearing disability, to be considered in achievement of sustainable development goal. The next slide, please. So here, in terms of disability under the sustainable development goal, actually disability is cross-cutting issue on this development goal. It's ranged in it's mentioned in goal number 4, 8, 10, 11, 16, and 17. And that, especially in the goal number 8, that the promote the sustained, inclusive, and sustainable economic growth, full and productive employment, and decent work for all, which is including person with disability. Then on goal number 16, violence against people, against person with disability, inclusivity, inclusive society. So move to the next slide, please. So now another thing is that globally, many countries, including Indonesia, have agreed with the UN Convention on the Right of Persons with Disabilities. As a consequence of one of the signatories country on this convention, Indonesia has collected data on disability, including hearing disability. However, the data is not available publicly, and also there is no further analysis, there is no further detailed analysis on hearing disability. So that is why this paper fill in the gap, especially on the demography of hearing disability. Next slide, please. The next one, which comes the importance of a study on hearing disability, is the presence of the COVID-19 in Indonesia and also in other countries came as an unprecedented outbreak, and that disrupted the livelihood of many people in many countries, and that Indonesia also not exception, which in fact this figure shows that the number of positive case in Indonesia is still quite high. As of 14th of December, which is about 2 days ago, the daily case is about 6,600%, which is in total make it is about 617,000 people, with the death rate is about 3%, or at the moment is almost 19,000 people dead because of the COVID. So what is that? Next slide. What makes the COVID-19 actually become more important to the people with hearing disability? Maybe you may have noticed this one, and I think maybe some of you is already know. It's already COVID-19 pandemic has worsened the suffering of the older people with hearing disability. One of the things is that because of the use of facial masks. So that comes the problem, the challenge for the people with hearing disability. And older people with hearing disability actually pose significant challenges to their families, particularly when there is limited or no access to the hearing care provider. So because of this COVID, in order to contain the spread of the virus, stay-at-home order. Earlier presentations is already mentioned that stay-at-home order also create anxiety on the issue on the mental health. And another thing for the people, the older person with hearing disability, the use of facial masks. Of course, what is that? What is the challenges of having this one? Next slide, please. So here the use of facial masks for the older people with hearing disability, or maybe not only to the older person, that make them difficult to recognize facial expression because they have trouble in reading lips. That is a key for them in the communications. That's one of the things that make communication for them is very difficult. If it's not impossible, it's hard for them to hear. And also, due to the closure of the clinic, people with hearing disability, they need to have regular check. So because clinics are closed, they cannot get regular physical check on the ear, and also they cannot have a physical fit or adjustment to their hearing aid. And another thing, they consume batteries to operate the hearing aid. So because the shop are closed, then they find difficulty to get or to buy the hearing aid batteries. Another thing, some of the studies also mention in UK, access to audiologists. Audiologists shifted their services from face-to-face care to remote care using teleaudiologists. So that's another challenge they have. Next slide, please. Another study mentioned that even when the older person with hearing disability have to be hospitalized, that's another challenge. They cannot accompanied by any family members who actually become the translator for them in a communication because they have to go on their own. This make even communication extremely difficult for them if it's not impossible. They cannot read the lip because of the professional health professional also using facial masks and also with other attire that make the situation is they're suffering is become more difficult. They suffer from ineffective communication and also feeling unsafe, and they think that they perceive that they have a poor quality health care due to face masking. Another study also found that COVID can have long-term consequences in which that more than 1 in 10 COVID-19 infected adults report a change in their hearing ability. So this one, if people who do not suffer from hearing loss, but then they got infected, so the COVID, it can be a new source for hearing disability. Not only because of the age or because of other source of hearing loss. Next slide. So that is why COVID-19 deprived the capability of hearing for the older person with hearing disability. Move to the next slide. Then here what they want. Here what they want for people with hearing disability, which actually this is an example. An example, then the first picture, here is a couple, Indonesian couple who's suffering from hearing disability. They are the deaf couple. So during this pandemic, they have difficulties in communication. But then the lady is actually a tailor. So she learned from Facebook, she learned from YouTube to create a face mask with plastic transparent in between so that they help communication. Other people can see them when they talk, and also they sell this kind of transparent mask to other people who need that. Then make the communication is easier. And also another thing for the people with hearing disability, the second picture is actually an example what the BKKBN in Indonesia use whenever they have a conference webinar. They have a presenter using the sign language. So transparent facial mask sign language, that's what the older people, that what people with hearing disability needed. And the next one is actually circulated on the internet that the more transparent, which is full face transparent mask that would like to have that. So this is some of the things that during this pandemic, and I think if COVID is still with us in the next few years, listening to the need of the people with hearing disability, it has to come to an action for providing communication is easier for them. Next slide. Next slide. This is the sum of the framework that I'm using in my study that hearing disability can have impact and also can have some of factors that associated with hearing disability. Aging is one of the things, but also chronic diseases, and another one is noise exposure. So which actually with the noise exposure is not only a study about hearing disability, not only for the older person, but also for the young people. Some of the study mention that consumption of the sound, especially using headphone, earbuds, Bluetooth devices, has also bring some risk to hearing loss. So please mind for us as well, whenever we attending the conference, maybe headphone the whole day, maybe not nice for us. We post to a certain of risk on this one. And then hearing disability also may be associated with unemployment, with subjective well-being, and also with communications. Next slide. Because of this, our study actually aims to what extent actually the prevalence of hearing disability among other persons in Indonesia, taking into account socioeconomic outcomes, socioeconomic variables, and also the second aim is to examine the relationship between hearing disability and the use of technology. The next aims is that to examine whether there is a relationship between hearing disability with communication, health, and also subjective well-being. And this will bring to a better understand the well-being of the older person with hearing disability. Next slide. And this study using the nationwide data based on the 2018 survey on the Indonesian National Socioeconomic Survey. So this one is not during the pandemic, but is that the pre-pandemic of the COVID. But I think for the case of hearing disability, it will give us more insight about the life of the people with hearing disability. Next slide. Our measure for hearing disability is using these questions. Do you have any difficulty in hearing despite wearing hearing aids? When hearing disability is not uniform, there are 4 options for this one. Yes, cannot hear at all. Yes, with some much difficulty. Yes, with some difficulties, and no difficulty at all. Next slide. Then on the measurement on the difficulties in communication, almost quite the same. Do you have any difficulty in understanding communication, and do you have any difficulties in controlling emotions? Next slide. So this is some of the other variables that take into account in these studies, and I think just move this one a little briefly. So go to the next slide about the finding. Yeah. Our finding shows here that at least 6 million people aged 55 and above with hearing disability. So here I'm using 55 and above, with actually the definition of the older person in Indonesia is 60 and above. That moving 5 years old earlier to compare between the older person and the pre-older persons. So from 2018, it's about 6 million people in Indonesia with different degree of disability, with different hearing disability, which consists of 5 million with some degree of hearing disability, and then 1 million with severe difficulties. So in terms of number, I think this one is quite huge, it's quite significant. From the policy perspective, so how we cater the need of people, other people with hearing disability. 6 million actually is much larger than the population, the whole population of Singapore, and especially many times of the Brunei population. That the older person in Indonesia who have difficulty in hearing. So you can sell, if that you can sell, we can provide hearing services for all these people, 6 million, if take into account with the younger one, which be much larger. So that make this important policy to take place in Indonesia with regard to hearing disability. Next slide. And taking into account in the next slide. So this one that in terms of our number, in terms of the prevalence is about 16%. It means that about 16 per 100 Indonesian older person aged 55 years and above, they suffer from hearing loss. And that hearing disability varies across different characteristics. Next slide. So this slide shows different age. So as the age get older, there is a positive relationship with the prevalence of hearing disability is increasing. And there is the difference between men and women. So before the age, below the age of 80, older women tend to have higher hearing disability than older men, while the opposite among those 80 and above, so that the oldest old is different pattern. More older men suffering from hearing disability. So taking into account place of residence, we have also almost the same pattern in which people living in rural areas tend to have higher hearing disability, yet the opposite is observed among the age of 80 plus with some difficulty in hearing disability. So the next slide take into account education. So from this slide shows that there is a positive, there is a negative association in which that the higher the education, the prevalence of hearing disability decline, which the most educated one, as I mentioned, have the lowest hearing difficulties. It's just about 5%, but for those without education and incomplete primary is above 20%. With regard to marital status, the next picture shows that married older person tend to have, sorry, back to the next slide, tend to have a lower hearing disability. But in this slide shows that education actually moderating the relationship between age and hearing disability. Next slide. Then in this slide, hearing disability in relation to the type of occupations. The older person with severe hearing disability, whether they work in informal, formal, or unpaid worker, they have they are the more they're suffering from hearing disability. So the older person, if the older person without difficulty, they have a higher probability to work. And also with regard to the industry, whether they work in agriculture, whether they work in manufacturing, and whether they work in the service sector, the older person with severe hearing disability has the lowest percentage of work. The percentage of working is smaller. The next slide. So next slide, linked to the use of technology. And I think this one relevant during the COVID pandemic, when the use of technology become much more and become a new norm for all of us to consume technology much more, especially using handphone, using computer, and also using internet. And then what happened to the older person in Indonesia is about 48%, yes, they use handphone, but only 37% they own handphone, and a much smaller percentage using computer, and using internet is only 8.7%, which is more information distributed or disseminated using this technology. And the next picture shows that the before we move to this slide, please go back to the earlier slide. Yes, from this slide, it shows that the more severe the degree of hearing disability, the lesser they own handphone, the lesser they use handphone, or the lesser they use computer and also internet. The next slide we use and looking at. Next slide here, looking at the hearing disability with the health status. So this slide shows that older persons with severe hearing disability are the most likely not in the good health. It's about 64%. They are not in the good health, in comparison to 46% for the older person without hearing disability. They are more likely in a good health. Taking into account when they are not in a good health, whether their the daily activities disturbed or not, it shows as well that the older person with severe hearing disability and their daily activities disturbed, also the percentage is higher in comparison to the older person without hearing disability. Next slide. Now, there's another important thing. Hearing disability is also, from this slide, hearing disability also associated with difficulty in communications. So let's take an example. If older person having severe disability, they are also having severe difficulty in communication. It's about 29%. So it's about 3 in 10 people. If they have severe hearing disability, they have also severe difficulty in communications. So difficulty in hearing is related to difficulty in speech or communications, and that during the COVID-19, many older persons may be more likely in social isolations because of this two type of difficulties. The next slide is linked hearing disability with difficulty in controlling emotions. So that the box with the red number, it shows that older person with two difficulties. They have hearing disability and also they have difficulties in controlling emotions. It shows from this slide that difficulty in hearing is also related to difficulty in controlling emotions or behavior. Therefore, during the COVID-19, many older persons may suffer from low subjective well-being. And I think some of the earlier studies also mentioned that one, regardless whether they have hearing problem or not, but for the older persons, the COVID situation has a negative impact to their well-being. So the next slide, from these two slides, shows that older persons may have triple difficulties. They have hearing disability and also they have difficulty in controlling emotion and they have also difficulty in communications. Next slide, please. To sum up, I think from these studies, so age, education, and marital status matters for older person with hearing disability. Older people with hearing disability are also suffering from double or triple difficulties. Difficulties in hearing, difficulties in communication, and also difficulties in controlling emotions. Then also they're more likely to be less employed and find limited access to the use of technology. Next, so that what is the recommendation that we have to think about here? Policies are preventing and mitigating hearing disability will be able to prevent and minimize other people hearing capability deprivation, and therefore improving social justice or inclusivity. So areas which need special attention on the promotion is that reducing noise consumption among young people. So this one of the implication from the older people experience to the young people as a mitigation. As a mitigation, and also a healthy lifestyle, train and rescale people, especially including the older people in digital technology. So then it will help the older people with hearing disability and communication and also access to information. Next slide. Minimizing the capability deprivation of people with hearing disability. First is that removing the stigma from wearing hearing aids. We talked about an example different type of hearing aids in this picture, and make it available and also affordable hearing devices for these people. At this moment, the hearing devices is still quite expensive. One for 1 year, it can take maybe for this month to buy one hearing aid, it can have 2 laptops or whatever. That one of the thing. That is why WHO mentioned that hearing people with hearing disability actually has economic cost quite significant. So the other one is educating the public not to discriminate people with hearing disability, especially during this pandemic, make the information more availability to them. So that's what I can share with you this afternoon. I'm looking forward to the comment and question, and I think this is the time for us to think about the access to the communication for the people with hearing disability. Because, next time maybe I'm afraid that with this conference also many other person which actually who want to know or who want to listen to this one, and especially for those who completely cannot hear, they cannot follow our conference because we don't have a sign language for them to attend. And I think I would stop here. Welcome to the question and also input and also our next step for the better of the life of the older person with hearing disability. I'll stop here and thank you very much for this opportunity. Thank you.
Okay, thank you, Dr. Evie, for your presentation. There are actually questions for you in the chat box, but we have to proceed to the next presenter. Could you please answer the questions in the chat box? The next presenter, I would like to welcome Professor Dr. Suzana Shahar from Center for Healthy Aging and Wellness, Aged Care, University Kebangsaan Malaysia.
Right. Thank you so much. Thank you for the organizing committee for inviting me to present a bit of our findings from our project in this very important conference. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So next slide, please. Yep. As what Prof. Tan Mopin, my colleagues mentioned that as per other Asian countries as well, we are seeing the increase in the COVID-19 cases in Malaysia, and our older adults or older populations are most vulnerable, and up to 62.6% of deaths due to COVID-19 involving those aged 60 years and above. Next slide, please. Sorry, can it be? Right. So I think we have quite a number of issues that we listened from this morning, and one of it is about the mental health. As we know that the pandemic has led into a global economic crisis due to the lockdowns and yield negative economic growth, with massive public health and social safety costs, including food insecurity. And in addition, those impacted by poverty or food insecurity are likely to experience additional resource-related hardships that in turn contribute to poor nutrition and mental health condition. And we know that nutrition and food intake play a significant role in the psychological health of older adults, which warrants further investigation due to limited information. However, the issues of nutrition and food insecurity are not being equally highlighted with respect to psychological distress during this COVID-19 pandemic. So next slide, please. So we aim to investigate the association between the habitual inadequate nutrient intake and among the older adults, and also the food insecurity and psychological health problems among older adults in Malaysia, and what are their coping strategies during the Movement Control Order or MCO during this pandemic. Next. So as what Prof. Tan Mopin mentioned, that we have two major longitudinal cohort in Malaysia, which is MELO and also LRJS TUA. For this analysis, we are using the cohort from TUA and also 3 other interventional studies, of which we included the assessment of habitual nutrient intake at baseline before the pandemic actually occurring. So we use about 535 middle age to older adults from these samples. We use the sampling method of purposive technique involving Selangor, Perak, Kelantan and Johor, and also the Klang Valley, of which we do some interview online during April to June 2020, which is during the first lockdown period in Malaysia. Now we are in the second lockdown for some of the states in Malaysia. So we screen those that able to speak in either Malay, English, Chinese or Tamil languages with no major documented psychiatric illnesses or mental disorders. And also we have to exclude those with hearing impairment, because our data collection is go through the telephones interview, of which we took about 30 to 40 minutes per interview. And this has been conducted by a very well-trained interviewers, 7 of them, from the health sciences background, which is nutrition, dietetics, physiotherapy. Next, please. So, So we have some social demographic data that we have collected earlier, because this is the cohort that we have, and plus 3 other interventional studies which is ongoing that we have to stop during the COVID-19 pandemic, that we make them busy by calling them to ask some of the questions during the pandemic. We have their baseline measurements that we took before, which is about 3 to 6 months before the pandemic, and some depression and functional status, and of course the food intake. So during the follow-up in April to June 2020 this year, we asked further questions on their living arrangements, current smoking and health status, and also the physical activity using the Malay version of International Physical Activity Questionnaire, short form, and also their general health questionnaire, GHQ-12, for their current psychological status. And it's also the Malay version. And we also administer the USDA Household Food Security Survey, consists of 6 items of questions on food security, and the flourishing scales to measure the subjective well-being, and also the coping strategies using the Malay Brief Cope scale. Next. So from this data, we look into the prevalence and so on, and run some univariate analysis, and further the binary logistic regression to determine the factors associated with psychological distress as measured using the GHQ-12. Next. And we also look into what are the factors that mediate the association between the predictors and also the outcome, which is the psychological health during this lockdown, using a progress macro in the SPSS software. And we differentiate what factors are the full mediator and what are the factors which is the partial mediators from the analysis. Next. So with respect to social demography, we finally ended up with samples about 500 over, of which the mean age is about 71.18 years. More older men as compared to women, and the percentage of women and men participating is a bit more for women. And with respect to ethnicity, it's about comparable for the Malay and Chinese, but not many of the Indians. And for the educational level, most of them is in the secondary education, followed by primary education. And this is slightly different from our national data, because our national data shows that most of the elderly is having primary education or no formal education. It seems that this cohort that we were able to actually communicate and follow up during this lockdown period are those who are more likely to be literate and having access towards at least a mobile phone or telephone. And 9% living alone, whereas the rest of them were living together with their family. And about 35.9% are still working, whereas the rest were either housewives or not working. Next. Next, please. Okay, we look into their macronutrient intake, and most of them are actually not having too much calories as compared to the recommendation. And their diet is actually more percentage of fat as compared to the carbohydrate, which is not so much, and very little fiber, and more of the protein. So more protein, more carbohydrate, less carbohydrate, more fat, and less fiber. So it seems not so balanced in that sense. Next. And with respect to micronutrients, some of the micronutrients met the recommendation, especially the vitamin A, carotenes, and vitamin C and vitamin E. But the rest, including the vitamin D, B vitamins, which is very important for energy releasing factors and also for nerve system and so on, are less than recommendation. Next, please. Same as the minerals, the traditional minerals associated with bone health, such as calciums, are also lower than the recommendation, and same as magnesium and also copper. Next. So we look into the socio-demographic variables and also some health status and smoking status and so on, and we tap those with normal psychological well-being versus psychological distress. Overall, there were about, not 13.6, but 12% were having psychological distress, especially among the Malays, more among the Malays and a bit of Indians as compared to Chinese. And years of education, more of those with psychological distress were having less years of education. It's not so high level of education, having some problem with GIT like ulcer or gastric. Next. And there were not so much differences on anthropometry or nutritional status with psychological distress, but there were association with depression, of which, of course, those who were having higher score of depression, as assessed using geriatric depression scales, are more likely to have psychological distress. And those who were having low physical activity, as indicated by the IPAC, we measure the MET, which is the metabolic equivalent for physical activity. They were lower physical activity as compared to the normal one. Next. And of course, the food insecurity, very high percentage of food insecurity, about 71.9% among those with psychological distress, as compared to only about 7% in the normal or no psychological distress. And some of the nutrients such as protein, cholesterol, fiber, and beta carotene, which is a provitamin A, vitamin K, and copper also related to psychological distress. Next. However, when all those factors we actually input into the binary logistic regression, overall that we're going to say that the psychological health or profile among the samples that we were able to follow up is considered as to be good because the mean score is low, with 12% having psychological distress. However, some of the factors, as I mentioned in the univariate analysis, we put into the binary logistic regression and adjust for some confounders. We found that the pertinent factors associated with psychological distress during the movement control order, wave 1, during this pandemic COVID-19 in Malaysia is living arrangement, which is living alone. And from the sample, about 9% of them are living alone. Low physical activity as assessed using IPAC or metabolic equivalent, and low flourishing scale indicating the low subjective well-being, food insecurity, and inadequacy in their diet, especially protein and also fiber. Next. Then we also measure the coping strategies during the pandemic, that we found that the Malaysian older adults try to cope with the lockdown and the pandemic, and the samples related to the main coping strategies during the pandemic is associated with religion and positive reinterpretation, acceptance, or what we call in Malaysia, in Malay language is reda, planning, active coping, instrumental support, emotional support, and followed by the rest. Okay, next. And we did some mediation analysis. For example, we found, remember, if as I mentioned to you that living arrangement, like living alone, is associated with psychological distress. But what coping strategies that mediate the association? And we found that living with family actually provide the emotional support that enable the older adults to cope well during the pandemic, and they were less likely to be psychological distressed. Next. We also look into the physical activity because we found that low physical activity is one of the strong factors were associated with psychological distress. And what are the coping strategies mediate this analysis? We found positive reinterpretation, instrumental support, which is a positive coping strategies. But there were also negative coping strategies such as denial and self-blame, which also came up into the analysis. Next. Next, please. And with respect to subjective well-being as assessed using flourishing scales and psychological distress, positive reinterpretation, instrumental support, humor, and again denial is the coping strategies mediate this association. Next. So as a conclusion, we found that overall during the first lockdown, movement control order of the pandemic COVID-19, of which at that time we felt that the situation is worse or is bad, but now according to Prof. Tan, it's even worse, right? So it means that we are coping quite well, I suppose. And only 12% who were psychological distressed, but those who were living alone, less perceived or subjective well-being, having food insecurity. Go back to the previous slide, please. Previous slide. Next. And physical inactivity were the factors. And some coping strategies were found to be mediate this analysis. And most of the older adults, when we called them, they said that they are happy at home with their family members, having forced to be working at home, that make them quite happy at that time. Next. And we suggest that in the future that there is a need to do some outreach program to those who were living alone and at risk of psychological distress. And in particular, that our response in this study is about 50%. So we were not able to communicate with the rest of the 50% who were more likely to be poor and not having facilities or communication facilities that allow us to contact them. And it's very important also to advocate healthy lifestyle, physical activity, and positive coping mechanism through formal and informal health and social care system among Malaysian older adults and their caregivers. Next. As I mentioned, that we realized that this interview, were done through virtual, through online, through phone, of which some of them with known hearing disability we have to exclude. But for those who were actually included, we are really not so sure whether they are really free from hearing disabilities. And as I mentioned, that 54% only the response rate. So the rest probably we couldn't reach. And we are now going into our second survey together with we are now on the FINGERS trial of our cohort to look into the multi-domain intervention among the cognitively older adults, of which 28 countries participating with the some set of questionnaires to look into the changes in lifestyle factors, management of chronic non-communicable diseases, and also psychosocial factors, and also social isolation. So we are doing this second survey. Hopefully we can compare what happens during the second lockdown as compared to the first lockdown as what I've presented to you. Next. References next. Next. Okay. So finally, I would like to thank my team, especially my postgrad student, Nurul Fateh Malik, Rivan, for helping me to share this data with all of you this afternoon. Thank you all.
Thank you, Professor Dr. Susanna, for your presentation. Now we come to the last presentation. With us are two presenters, Assistant Professor Dr. Rahul Malhotra and Dr. Abhijit Visaria from Center for Aging Research and Education, Duke NUS Medical School, Singapore.
Sure. Thank you, Prof. Thanks for the introduction. So I'll be co-presenting this work with Abhijit, who I guess you also see on your screen. We are from the Center for Aging Research and Education in Singapore, based at the Duke NUS Medical School. I can't see the slides. If you could get the slides up. Thank you. So I guess we followed the brief that was given in kind of the pre-conference notes of presenting kind of an overview of research on aging in Singapore, and specifically talking about some research that kind of details the impact of COVID-19 on older people in Singapore. Next. So I'll be talking briefly about the population aging scenario in Singapore, just presenting some demographic numbers there for your consideration, followed by an overview of key aging research centers and institutes in Singapore. What are they? What are their main focus areas? And some population-based cross-sectional and longitudinal studies that are ongoing in Singapore. Followed by a brief description of some of the research funding mechanisms for COVID-19 that have evolved in Singapore over the last few months. Thereafter, Abhijit will talk about the findings, an overview or the findings from two COVID-19 related research projects among older people that are either ongoing or have been completed. Next. So I apologize. I don't know whether you can see the numbers there, but okay. So in Singapore in 2020, based on the media population estimates for this year, there are nearly 900,000 older people, which is a nearly threefold increase from the number of older people aged 60 years and above in the year 2000. The absolute number, of course, pales in comparison compared to many of the other countries that are represented here in the meeting or in the ASEAN region. But of course, if you see the population base, which is just over 5 million in Singapore, the proportion of older people is quite high. So the proportion of older people as of today in Singapore is 22.2%. So 1 in 5 persons in Singapore, 1 in 5 residents in Singapore, citizens or permanent residents, are age 60 years and older. Next. It's also interesting to look at the age distribution, because we must remember that all older people are not the same. There is a wide kind of variability of health situations and other conditions within older people, so we should never lump them together as older people and just talk about them as one group. And then this kind of shows the fact, again, just breaking up simply by age, we do realize that in Singapore, the proportion of people who are aged 80 years and above, an age where most of us who work with older people realize is where a lot of things start going wrong in terms of functional limitations, in terms of health conditions, in terms of kind of general debility and frailty, has increased just over the past 2 decades, and it's likely to continue to increase as well. Next. I mean, the cause is not different from other countries. So this is just presenting kind of the two drivers of population aging: life expectancy, and on the next slide I'll present total fertility rate. But again, you see life expectancy has been increasing in all the countries in the ASEAN region, but Singapore, if you may, is the topmost kind of line of dots there, which has been higher than most of the countries, and the slope also has been consistently high throughout since kind of the middle of the last century. Next. In terms of total fertility rate, it's a similar situation. All the ASEAN countries have experienced declines in fertility over the last 20, 30 years for sure, and even before that. But if you see the line for Singapore, that kind of stands out. It's the lowest for sure, but also the decline, the speed at which it has declined from the 1960s till the 1980s has been very dramatic. And these two kind of factors, which are the relatively rapid decline in fertility over a short period of time, coupled with the consistently high life expectancy, has led to the situation that we presented, that you saw before, which is the high proportion of older people in Singapore. Next. So of course, I mean, given the focus on older people in Singapore, there has been a lot of kind of policies and programs that have been implemented by the government, including kind of the large action plan for successful aging that was put in place in 2015 and is in the process of being revised. But in addition to kind of policies and programs, there also has been a concerted effort to set up aging research centers in Singapore across universities or hospitals. And this is just a list of the 11 centers that are either existing, and the last one, this proposed Center for Productive Longevity, is in the works at this point. And I won't kind of go through the details, just to kind of highlight a few. So the center I come from, which is number 2, Center for Aging Research and Education, is at the Duke NUS Medical School and focuses on psychosocial aspects of aging. We also do research on clinical aspects of aging, so a bit of geriatrics. Care integration in the community is a big focus. Family caregiving is a focus, as well as we work closely with the Ministry of Health in Singapore for evaluating policies and programs and pilots that have been implemented by the ministry or its agencies. Other centers kind of do similar work or different work. For example, number 4, the Center for Healthy Longevity, the key focus is on the biology of aging. Number 9, Lily, has a focus on AI and on technology. Number 8 has a focus on end of life care. So there is some overlap, but also kind of each of the centers have their own distinct areas and distinct advantages, if you may. Next slide. So there has been also be a concerted effort over the past 2 or 3 decades, especially in collecting data on older people. Of course, all of us who work in policy or in research realize that we can't formulate policies, we can't get recommendations without good data. And there has been an effort to do both cross-sectional as well as longitudinal data. So the major cross-sectional studies, of course, these are just one of the few major cross-sectional studies which are either nationally or regionally representative. Of course, there are a lot more smaller cross-sectional or longitudinal studies that have been done either with a specific subgroup of older patients of a specific disease or in a limited geographical region. and some of them are broad health surveys, similar to kind of the US HRS, if you, I mean, all of you are familiar. So it covers a very broad set of factors that are assessed among older people. Some of them focus on certain issues. For example, the eye studies focused on the eye. The SG90 longevity cohort focuses on the oldest old and assesses factors for successful aging among centenarians and nonagenarians. TRACE, the first longitudinal study that I've listed, is specifically focused on caregiving. So, of course, I don't have time to elaborate on all of these, but if you're interested, you can read our paper that was published in the Gerontologist last year on Singapore, which kind of describes the aging centers as well as the aging of Singapore in a summarized manner. Next. So, shifting gears to COVID. So, COVID-19 has impacted Singapore for sure, but luckily, I guess, with the concerted efforts of the government and the population, the situation has been under control. So overall, we've had just below 60,000, so around 58,000 odd cases still as of yesterday, with only 29 deaths. Most of the cases have been among dormitory residents. So in Singapore, we have a large proportion of foreign workers. These would be young men who are living in dormitories and they work on work sites, construction areas, shipyards, and ports, and so on. So most of these, 93% of the cases, are among dormitory residents, with only 4% of the cases among community dwelling Singaporeans and 3% of the cases being imported, so people who are coming from outside Singapore. As the situation is in other countries, most of the COVID cases are among younger people, less than 60 years of age, but unfortunately, most of the deaths are among individuals who are aged 60 years and older. So even though the case situation has been relatively kind of stable in Singapore and it hasn't really resulted in a major outbreak, of course there was a period in early part of the year where the situation was kind of much more dramatic, and there was a circuit breaker, that was the name given to the lockdown that was initiated in Singapore, was there for a period of 8 weeks or so. And concurrently with that, there has been a research focus as well. And this slide and the next one just present the major kind of themes. And there has been an effort from both the medical and the social perspective. So the NMRC grants, the first ones that are listed, mostly focus on either outbreak control or management, which is more the basic sciences or the epidemiological aspects, or clinical trials for development of therapies. The NRF grant, which is the second set that I present there, are much more smaller grants that are focused on immediate actions, process actions that could be taken to improve service delivery within a short period of time. Next. So the social science research grant, as the name suggests, is much more focused on the social science and humanities aspects of the COVID-19 epidemic in Singapore. And then, of course, we have the National Innovation Challenge, which is an ongoing perspective, which again kind of speaks to some kind of, it has different tracks. And there was a track under healthcare that specifically also targeted COVID. Next. So of course, there's a lot of research that has been funded, and there's a lot of projects going on, and then people could just be duplicating each other's study. And therefore, on the National Medical Research Council website in Singapore, there has been an effort to put all the studies that have been funded, and some of the descriptors are you can see on the slide. So individuals who are interested in a certain topic could directly contact the principal investigator and not duplicate. And that's also kind of an interesting initiative, because this is a evolving situation, and there may be people who get the same idea at the same time, and you don't want two people to work on it, and it's best if they can work together on it rather than compete with each other for the same set of resources. So that summarizes kind of the overall COVID-19 research funding in Singapore, and I'll now leave it to Abhijit to talk about specific research projects and overview and the key findings of COVID-19 and older people in Singapore. Thank you.
Thanks. Next slide, please. Right. So this is one example of the type of project that has been funded by the Singapore National Medical Research Council under its COVID-19 Research Fund, and it combines elements of outbreak control, management, and modeling. And I'm sharing this as an example because it is the type of research that brings together existing administrative data that is routinely collected by the health system with methodologies that are help obtain a macro level or a systems perspective and individual level patient and stakeholder level experience and narratives as well. So it's called COVID SOS in short, and the full form is COVID-19 Virtual Disease Health System Outbreak Model for Singapore. And the core of it is a system dynamics model to identify key policy levers. And these could be institutional level redesign or policy level interventions, which help estimate the impact on healthcare utilization patterns, on morbidity, mortality, as well as the costs of care. Interestingly, it is also a mixed method study, and it is interviewing about 60 patients to get insights into patient experience about seeking healthcare at the time of COVID-19, issues such as scheduling and quality of care, communication, the access to information. It's also interviewing about 30 stakeholders, and these are stakeholders at all levels. So across frontline, including frontline workers, managerial staff at healthcare facilities, as well as policymakers. And the idea is to get their perspectives on workforce task allocations and adjustments, how reallocations as far as staffing and costs were done, how decisions on redesign and prioritizing specific type of health services were taken. Next slide, please. So this is just the conceptual sort of model that the COVID SOS project is following, and as you can see, it covers a study of the health system and various outcomes and costs related both to COVID as well as non-COVID conditions, because obviously the health system is affected by both COVID-19 and it has effects on non-COVID conditions and the individual's healthcare utilization and costs, etc., and health-related outcomes of non-COVID conditions as well. Next slide, please. So an example of the type of data that the COVID SOS project uses for its modeling and helps analyze as well is which clinical services, for example, have been displaced because of COVID-19. And you can see in this graph that, although it's probably not terribly clear, but the idea is that while overall surgeries, as you see within this rectangle, certainly declined after January, the ones that declined in particular were day surgeries and to a smaller extent elective surgeries, but not so much emergency or urgent surgeries. Next slide, please. Right. So this and the rest of the slides that I will talk about are based on the Singapore Life Panel study, which is a monthly survey of about 7,500 older adults in Singapore, age 50 to 74 years of age, and it's run at the Center for Research on Successful Aging at Singapore Management University. And some of us at CARE at Duke NUS also associated, collaborating and investigators on the study. So among this age group of 50 to 74-year-olds, those who had at least one of those chronic conditions that is listed on top of the slide, a question was asked in July 2020, whether they had faced any interruption in appointments for any of their chronic conditions since Singapore's disease outbreak response system condition or the color went from yellow to orange back in the beginning of February. And that, of course, signaled that there was community transmission of COVID-19 going on. And the idea was that at that time, since the beginning of February, had individuals faced interruptions in chronic care, and about 2 in 5 or 41% said yes. And if you see on the right side of your screen, the site of interruption where they had these appointments cancelled or postponed were primarily, or the vast majority were hospital outpatient clinics and to some extent polyclinics as well. Next slide, please. And so then, if you look at the breakup of this data in terms of which subgroups were more or less likely to experience this chronic care interruption, what we find is that older adults at older ages, so the 70 to 74-year age group, and females had higher proportions of chronic care interruptions, and so did more educated adults, although that probably suggests that they may have had more appointments to begin with. Next slide, please. And just dwelling on this a little more, those in worse health compared to those in good health, and those with more chronic conditions. were also more likely to experience chronic care interruptions since DOSCON Orange, or since February, between February and July. Next slide, please. So among those who reported that they had had a chronic care interruption, we asked a follow-up question, which was, in their opinion, did postponing or cancelling the appointments lead to a worsening of the chronic conditions that they have been diagnosed with? And about 1 in 10, or about 11%, said yes. And on the right side of the screen, you will see that the highest proportion was where hospital inpatient care was where the appointment had to be cancelled or postponed. Next slide, please. We also asked respondents whether concerns about contracting COVID-19 infection themselves, or concerns about one of their family members contracting or getting infected with COVID-19 played a role, or was one of the reasons for care interruption. And about 1/3 of the respondents said yes. And again, we sort of looked at where what was the site of this care interruption, and you find that sort of concern about COVID-19 contributed most where inpatient hospitalization or residential long-term stay, for example, in nursing home, was involved, followed by outpatient clinics such as general practitioner, dental clinics, and so on. Next slide, please. We also had a question that was asked in the August round of the Singapore Life panel, whether, and this was asked to caregivers, whether what was the impact of the circuit breaker, which was the lockdown in Singapore, on caregiving. And you see that about 37% or so, a little over 1/3, reported that it was somewhat more difficult for them to provide care. 45% of the respondents said that they were managing the same as always, and about 18% or so actually said that it was somewhat easier for them to provide care, potentially because these caregivers who were responding maybe were staying in the same location, same residence or household as their care recipient. Next question, please. Next slide, please. And so then the other sort of three things I want to present are things again from the Singapore Life panel. And this is essentially looking at how life satisfaction and satisfaction in various domains related to the social and family life, daily activities and job, about income, about an individual's economic situation and health, how they have changed since January 2020. So recall that January 23rd was when Singapore reported its first COVID-19 case. And as I just mentioned, it's about orange when February when the DOSCON level goes from yellow to orange, and that's when community transmission has started occurring. And you see that there is a decline as far as overall life satisfaction is concerned, but across all different domains. And the decline actually increases over time compared to January. Next slide, please. So we also had questions on perceived social isolation. And what this essentially shows is that between April 2019 and April 2020, what were the reported average levels of perceived social isolation? And you see that sort of between April and January or so of this year, between April last year and January or so of this year, remains more or less at the same levels. Although starting in January, perceived social isolation starts to increase, and you see that the slope in terms of increased perceived social isolation is significantly higher, is greater amongst respondents who live alone. Next slide, please. And finally, we had some data on what was the sources from where respondents were getting information about COVID-19. And this is by the educational attainment of the respondent. And you see that for across all the three educational categories, the most widely cited source, or the most frequent source of COVID-19 information between May and June of this year was the television or the radio. And then you sort of start seeing that, there are some effects as far as individuals who are, let's say, more highly educated. They seem to be accessing information through newspapers, to government sources. For example, the government set up a WhatsApp group, which is essentially this broadcast that sends out messages twice a day now, but about both the levels of COVID as well as messages, advisories targeted at specific groups. So we had, directly the government as a source of information. There was also the Interministerial Committee on COVID-19 that has also been having press conferences on a regular basis. But as you see, for over half of the post-secondary and higher educated older adults, this was a source of information, but it was only about 25% or so for those only with primary or no education. Social media, I mean, this was said earlier in the day, is also a source of information for about between a quarter, 25% to about 40%. Friends and family, interestingly, was not cited as a source of information by very many people, only about 1 in 5 or so. But interestingly, I mean, the significant effect that we see there is that those who are at lower levels of education have relatively more friends or family providing them information on COVID-19, not so much, only about 1 in 5, as I said, for those at secondary and post-secondary education. And internet, as one would expect, is not a major source. I mean, where the individual is doing his or her own research, and that was low at all levels. But again, those who had higher levels of education were more likely to access COVID-19 information through doing their own internet research. I think that's it. Do we have a next slide? Right. So I just wanted to acknowledge. I mean, this is work that is across two major studies and several institutions that are involved in this. And that's it. We'll be happy to take your questions. Thank you.
Thank you, Dr. Rahul Malhotra and Dr. Abhijit Visaria. Thank you to all speakers for the informative and interesting presentations. Distinguished guests, ladies and gentlemen, to end our conference today, I would like to invite Associate Professor Insinyur Dr. Siti Annum Ahmad, Director, Malaysian Research Institute on Aging, University Putra Malaysia, to deliver the closing note.
Thank you, Madam Chairperson, Dr. Hayati. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and a very good afternoon. It's a rainy season, it's a heavy rain here in Malaysia. Okay, first and foremost, may I, on behalf of the Malaysian Research Institute on Aging, University Putra Malaysia, say a brief word of thanks, especially to our co-organizer, National Population and Family Development Board Malaysia, NPFDB, and also our strategic partner to the United Nations Population Fund, UNFPA Malaysia. Without them, we would not have had such a remarkable time today. Thank you to all our participants for attending the Conference on Research on Aging in the Pandemic Age, Regional South-South Perspectives. Please accept our deepest apologies for the technical glitches in the morning session. South-South cooperation is a demand-driven, reciprocal and ownership-oriented model for designing and implementing collaborative initiatives among developing countries. This is an opportunity for us to use the already established networks to address the institutional and capacity gaps among countries related to population and development, particularly on the need for us to respond to the needs of older persons in light of the current pandemic. I would like to thank Mr. Najib Asifi, UNFPA representative for Malaysia and country director for Thailand, Yang Berusaha Tuan Haji Abdul Syukur bin Abdullah, Director General NPFDB, and Dr. Rintaro Mori, Regional Advisor for the UNFPA Asia Pacific Regional Office, for taking out time to speak at the conference this morning despite your busy engagement in the ongoing schedule. I would like to express my deepest appreciation to our fellow country speakers from Asian members, that have shared their experience and insight in COVID-19 and aging studies in their countries. Thank you very much for your contribution and support to the conference. Today, we have speakers from Brunei Darussalam, Cambodia, Vietnam, Indonesia, Philippines, Singapore, and last but not least, from Malaysia. Unfortunately, our friends from Thailand, Laos, and Myanmar are not able to join us today due to other commitments. I'm happy to note that for all the contribution today, the objective of this event have been achieved. One of the issues that we withdrew from the session today are the importance of digital learning or digital literacy in this pandemic age. Way forward, I'm certain that many issues that we have heard throughout the conference could be applied in our country. We will definitely summarize all the information and include them in our report that will be released next year. Next year sounds still very long time, but we're already in December. Tomorrow will be another interesting day as we will have an interactive session. We will have a regional workshop on research protocol and aging. The aim of the workshop is to identify and develop a common set of variables for a future comparative research on aging in Asian member states. We will look into 5 main variables, which are health, economic, social, psychological, and environmental. The workshop is to promote the exchange knowledge, experiences, and best practices on situational analysis research on COVID-19 in Asian pertaining to aging. The expected output is a standardized protocol for major aging research in Asian and a compilation of ongoing research on aging in this research. 2020 is a very challenging year for all of us, and we have to embrace with this new norm, including today our session, we have to conduct it as a virtual event. Nevertheless, I hope 2021 will be better for all of us. With that, thank you very much. Take care and stay safe, everyone. See you tomorrow.
Thank you, Associate Professor Insinyur Dr. Siti Anom. Ladies and gentlemen, that wraps up the first day of the conference. On behalf of the organizing committee, thank you all for making time in your busy schedules to join us today. To all the participants, please be reminded that we will begin the workshop tomorrow, same time at 9 a.m. Thank you again, everyone. Have a good rest and see you all tomorrow.